Good morning. This is Dr. Muthukumaraswamy, Professor of Medicine, Lakshmana Institute of Medical Sciences. In this class, I am going to deal about the hemiplegia. This paralysis definition of the hemiplegia is unable to use the one half of the knee. It is the paralysis of one side of the body, the tract lesion. It is the pyramidal tract lesion. It may be at any point from its origin from the cerebral cortex down to the fifth cervical segment. That is beginning of the origin of the brachial plexus. Below that, all come under the element lesion, above that it is upper motor neuron lesion. That's pyramidal pathway. From the cortex, they convert and they attain a place called the internal capsule. The fibers are converted and they descend down and they take us to the opposite side at the pyramidal level. Then descend is the cortico-spinal tract. That is our main motor pathway. This is it ends in the spinal cord. These are the places: cortex, internal capsule, at the level of midbrain, from its upper pyramidal medulla, the medulla lower part. Here, at the upper part of medulla, it decussate to the opposite side. The causes, the etiology are many. First we tell about the vascular causes: the thrombotic, embolic, hemorrhagic. This is monocytes on site of endothelial injury. The endothelial injury acts as a nidus for the infection and the aggregation of the platelets, causing the platelet adhesions, causing the obstruction of the partial artery, that causing the embolic. Next, ischemic stroke. See, here, the area, a particular area, is deprived of a particular deprived of blood supply. There is ischemia to the particular area. Here, the obstruction blocks the blood flow to part of the brain. That's a particular part. In hemorrhagic stroke, what happens? In hemorrhagic stroke, what happens? The area of blood is leaked there is a leak from the cerebral vessels. Weakened vessel wall ruptures. Here you see, causing bleeding to brain. Because brain is encased in a very strong box, a skull. You cannot expand more. This is how the area of ischemia here the area of ischemia, hemorrhage. The differential diagnosis talks about the acute and subacute onset. They are infective, viral, and brain abscess. Traumatic demyelination, hysterical. Gradual onset, very long duration. It usually the etiology is neoplasm, long years duration. The intracerebral and subarachnoid. The bleeding is in the brain substance. The mainly came to the ventricles. The commonest artery causing intracerebral hemorrhage is lenticular-state branch of the MCA, medial cerebral artery. The etiology is the lenticular-state branch of the medial cerebral artery. Then second comes the subarachnoid. The bleeding is in the subarachnoid space. Onset and course. An acute onset and regressive course. Vascular, infective, and traumatic lesions are the main causes, as I have told you. The acute onset, regressive course. A gradual onset and progressive course, usually neoplastic lesions. In relapsing and remitting course, in multiple sclerosis. Also, one of the chronic or subacute or chronic infection, multiple sclerosis. Symptoms and signs. According to the onset and site of the lesion, site of the part affected. Acute lesions, the kidney picture passes through two stages. Stage of flaccidity due to neuronal shock. That is cerebral shock stage, it is always called as flaccidity, no activity. Then stage of spasticity, which is the stage of established hemiplegia. During the cerebral neuronal shock or cerebral shock, we don't have any clinical findings. The second stage only we can have the spasticity, increase tendon and everything. There is upper motor illusion findings we can find. And gradually, the hemiplegia passes directly to a stage of spasticity, not like this. In acute lesions, initially there is no activity, then hemiplegic features. In gradual lesion, just directly go to the stage of spasticity. Stage of flaccid paralysis, shock stage. It lasts from 2 to 6 weeks. The duration is usually. It is characterized by decreased tone, flaccidity, decreased or last deep reflexes, DTR, and absent plantar response, flaccid stage. During the recovery from the shock stage, the muscle tone and deep reflexes reappear gradually, increases to the hemiplegic state. The Webnick sign becomes positive, then the spasticity section, then finally the Webnick scale becomes extensor response. That is Webnick sign. That is plantar. It is one of the superficial reflex. Plantar is not a deep reflex, only differentiating point. It is the superficial. All other reflexes are deep tendon reflexes. Plantar is a superficial reflex. Clinical picture. Spastic stage paralysis, hypertonia, accelerated TTR. That is your deep tendon reflexes. Last superficial reflexes. Positive Webnick sign. Here, all superficial reflexes are lost. Gait. Gait is different in spastic state. So the typical gait for hemiplegia is circumduction. That will come at the last stage or later stage during the recovery period, not now. Basal nuclei. Masses of gray matter, they are situated deep within the cerebral hemispheres to produce dopamine, basal nuclei. They control muscular activities, primarily by inhibiting motor function. They are caudate, basal nuclei, caudate nuclei, vitamin, globus pallidus. This basal nuclei. This is the longitudinal fissure. Right cerebral hemisphere, thalamus, hypothalamus, brainstem. The posterior part is our cerebellum. Then finally, spinal cord, occipital lobe, parietal lobe, temporal lobe. This is our frontal, temporal, parietal, and occipital. Between cerebral hemispheres and above the brainstem surrounds the third ventricle. Cerebral hemisphere, here lower this brainstem, in between the third ventricle. The third ventricle consists of here thalamus, epithalamus, hypothalamus, optic tracts, optic chiasma, infundibulum, pituitary, mammary bodies, pineal gland, and everything is here. Optic tract, mammary body, pituitary gland, optic nerve, optic chiasma, pons, cerebral tract, cerebral peduncles, thalamus, third ventricle here. The third ventricle is situated here. The pineal gland. Here lies the fourth ventricle, cerebellar peduncles, medulla oblongata, and finally the spinal cord. Thalamus. Gateway of sensory impulses leading to the cerebral cortex. This is all the sensory impulses except smell. Channels impulses to appropriate part of the cerebral cortex for interpretation. This is the relay, we can say. This is the relay between the peripheral impulses and to the brain. Epithalamus, it functions to connect the limbic system to other parts of the brain. Hypothalamus maintains homeostasis by regulating visceral activities. Links nervous and endocrine system. Hence, some say this is neuroendocrine system. Hypothalamus, neuroendocrine system. The limbic system consists of portions of frontal lobe, temporal lobe, hypothalamus, thalamus, basal nuclei, and other deep nuclei. The limbic system functions, control emotions, produces feelings, interprets sensory impulses. Brainstem consists of three parts: midbrain, pons, and medulla oblongata. This is diencephalon, hypothalamus, thalamus, corpus callosum, midbrain, pons, medulla oblongata, corpora quadrigemina, cerebral aqueduct, reticular formation, and finally spinal cord. Spinal hemiplegia at the level. Spinal hemiplegia at the level ipsilateral local element lesion. Ipsilateral local segmental sensory loss. Ipsilateral at the level, that is at the level ipsilateral element lesion plus local sensory loss. Below the level, ipsilateral hemiplegia, deep sensory loss, decreased touch. In contralateral, loss of pain and temperature regarding spinal hemiplegia, decreased touch. Here, ipsilateral hemiplegia, other side, loss of pain and temperature and touch. Here the so many places. This is cerebral involvement. This is brainstem involvement. This is finally our spinal cord. Here the changes in the eye, the changes in the fine movements, because in hemiplegia, first to last is fine movements. Coarse movements you can maintain for some time. You can have the coarse movements for some time. But fine movements, the first to last and the last to recover. It is first to last and last to recover. Syndromes. Weber syndrome, sight of lesion, hemiparesis alternans, oculomotoria, ipsilateral side, oculomotor palsy, pyramidal, contralateral side, hemiparesis, this Weber syndrome. Benedict syndrome, ipsilateral side, oculomotor palsy, contralateral side, hemiplegia, and hemiataxia. Here is in the red nucleus, that operation. Weber syndrome. An elaborate view of the Weber syndrome. Oculomotor nucleus nerve, red nucleus, substantia nigra, cerebral peduncle. This is first ptosis. Three signs. Ptosis, anhidrosis, ophthalmoplegia. Ptosis, anhidrosis, ophthalmoplegia. Anhidrosis. Same picture. This is normal, this is ptosis. So, pyramidal involvement. Syndromes. Miller, Gobler, hemiparesis alternans, facialis. This is Miller-Gobler syndrome, sight of lesion, cranial nerve, 6th or 7th. The second site is corticospinal tract. Ipsilateral is 6th and 7th lesion, contralateral side, hemiparesis, Miller-Gobler syndrome. Here you see the same explanation. Ipsilateral 6th or 7th nerve, contralateral hemiplegia. Here 6th and then ipsilateral 6th and 7th, contralateral. You see the position. The hand position is hemiplegic position, this is. You can find even the patient as he enters into a room. You can just diagnose. Yes, Foveli syndrome. It's called as Foveli syndrome. Sight of lesion, abduction paralysis, horizontal gas paralysis. That is ipsilateral side, 6th nerve, and horizontal gas paralysis, hemiplegia on the contralateral side. Horizontal gas paralysis, abduction paralysis, contralateral hemiplegia. Then Avilis syndrome. Involvement of 9th and 10th nerve, hemiparesis on the contralateral side, ipsilateral 9th and 10th. Jackson syndrome, involvement of the 11th and 12th cranial and hemiplegia. Already repetition of the same picture, we already different places. You can skip it up. Cortical lesions, 4C. Cortical hemiplegia, 4C. Contralateral hemiplegia first. Cortical sensory loss, coma, convulsions of transit. If any person with hemiplegia, convulsion occurs, you hear a history from the relatives or nearby attenders. And finally, aphasia. Contralateral hemiplegia, cortical sensory loss, coma, convulsions of transit, aphasia. Please remember. Internal capsule. This is anterior upper half and lower half, anterior genu, anterior limb, posterior limb, and genu. Associate fibers, visual, auditory, and sensory, three types of fibers, posterior limb. MCA, totally from the middle cerebral vertebral ventricular tail branch and the cubital artery and the thalamo-genicular artery for the posterior. This is the blood system. In capsular hemiplegia, there is no hemorrhage. H. Subcortical. It is in between cortex and the brain. Cortex and the brain. Is this question? Just skip. Investigations. Protein, as your blood glucose, liver and kidney function, lipid profile, CBC. CT will predict the presence of infarction, hemorrhage, or brain tumor. If it is a hemorrhage, we should not use the aspirin. It will worsen the condition. So immediately we rush the patient to take the plain CT and we confirm whether it is an infarct or hemorrhage or any SOL as brain tumor or any other thing. There are so many things. Actus SOL, they are uridated cyst, neurocystic psychosis, tuberculoma, phantom tumor. There are so many things act as a brain tumor, the SOL. MRI brain tech to detect the presence of infarction, hemorrhage or brain tumor, encephalitis, multiple sclerosis, plaques. And in addition to that, the age-related things for old people, senior people, they have got some age-related changes. That is important. So MRI brain is advised than the CT brain. Usually. Some other pictures we can go through here. Position is temporoperative area. Here, there is shift of midline, you see? There is shift of midline. That's due to the shift of midline. Here there is input view, that is front operator. Very, very, very huge. It is extending the midline and going up. Is small. So this is the serial pictures 1, 2, 3. It follows, it slowly enlarges and attains the maximum size. Okay? Vascular imaging is your Doppler ultrasonic imaging for carotid and vertebrobasal arteries. Transcranial Doppler, CT angiography, MR angiography, digital substrate angiography, it visualizes the intracerebral vessels. It is non-invasive as it requires a contrast medium given intravenously. Cerebral angiography, it is the most precise method showing any occlusion or stenosis in cerebral vasculature. Other investigation according to the cause, echocardiography and ECG in cardiac cases. Why ECG and echocardiography? Infarct, there is a infarct, SOL are within the brain. Embolic, thromboembolic, SOL, hemorrhage or lesions within the brain. The emboli is from the other parts of the body, usually in mitral stenosis. Vegetation from the mitral valve may dislodge and act as an emboli or any orthopedic maneuvers, which we would have already fat or tissue embolism may act as a emboli. Stop anukuda. This management care of the skin, frequent change of the position to avoid bed sores, bed sheets and bed sheets, frequent wash of skin for the back and pressure points, suction of nasal and pharyngeal secretions, water inhalation via catheter or mark, especially in case of coma, tracheostomy in urgent cases. Care of nutrition fluid balance, tube feeding, NST, NGT, nasogastric tube, your Arne-Riles tube, giving fruit juices, milk and pureed food, bedside IV fluids in comatose patients, care of the urinary bladder, Foley self-retaining catheter in case of retention, guarding against DVT by subcutaneous injections of anticoagulant and wearing elastic stockings, lower limb. But here, the frequent changing of position plays a main role. Specific, the treatment at cause. If the cause is cerebral thrombosis, control of vascular risk factors such as hypertension and diabetes and dyslipidemia, the regular drugs should be given, the antihypertensives or the anti-OHR insulin or dyslipidemia atorvastatin and your clopidogrel and the required doses. Antiplatelet because the platelet accuracy decreased after thrombosis, aspirin, dipeptidyl, and clopidogrel. Nootropic agents, paracetam, and pentaxephylline. But the use of pentaxephylline nowadays is obsolete and it is rarely used. The main function of the pentaxephylline is changing the shape of the RBC, to enter into the very narrow space to reach the perceptibility to the affected area. If the cause is cerebral embolism, treat the source of the emboli. Anticoagulants are given in the cardiac cases to prevent further embolism, especially in case of atrial fibrillation mitral stenosis. Or there may be emboli or blood clots in the chambers of the heart in mitral stenosis. The cause is cerebral hemorrhage, general care, control of vascular risk factors, and dyslipidemia, hypertension, diabetes as usual. Surgical evacuation of the hematoma in certain conditions. Usually very rare. The cause is cerebral inflammation, trait of meningitis, and incompatible with the higher antibiotics and other supportive care. If the cause is brain tumors, surgical removal. In case of multiple sclerosis, steroid therapy, a pulse steroid therapy course can be attempted. Management, physiotherapy, proper position of the hemiplegic site, passive and diatic exercise after stabilization of the neurological condition to minimize contractures and strengthen the muscle. This is more important. If you don't leave the patient, they will have contractures. Don't massage. More important.